Okay, so for those of you who are new to Serious Scholar, I'm Loué. I'm a doctor who is trained and working in the UK, but I'm originally from Syria. And with the help of my brother Keenan, we've set up Serious Scholar as a way to give any students, or any medical students in Syria who want some extra tutorials, a chance to go through some topics in addition to their university teaching whilst we're out there. So, today's session is going to be on emergency management. And it's all going to be about having a systematic approach that we call the ABCDE approach. And very, very soon, you're all going to be fully qualified doctors and working in a real hospital. And the first time you come across an emergency, you're probably going to feel something like this. And that's pretty normal. But the trick is to always, as with everything in medicine, have a system that means when you find yourself in a situation where you're a bit stuck, you can always fall back on it and that you know exactly what to do. And when it comes to emergencies, the key is to know really well the ABCDE approach. And as long as you remember that, no matter what the emergency situation is, if it's somebody who's having a heart attack or a septic shock or is bleeding, then as long as you fall back on ABCDE, you'll always be able to make sure the patient can stay stable long enough for more help to arrive and for more management to be put in place. So let's imagine a situation now. So let's go to the future a bit. You've just graduated. You're now fully qualified doctors working in your first job in hospital. And one of the nurses has come up to you and said, "Doctor, there's a patient in bed 3. They look really, really unwell. I don't know what's wrong with them, but I think you need to come over and help them quickly." And so you go over to their bed and you walk in and you see a patient. And this patient is almost unconscious, not responding much. He's got lots of vomit around his mouth. And you start to panic, but then you remember your ABCDE approach and you start with A. So who can tell me what the A in ABCDE stands for? You can type answers in the right-hand side of the screen. So if you just type a message in the box, I'll be able to see them. And we can be a bit more interactive that way. Excellent. So airway, Simon said. So first step is airway. So this patient, who we've walked into his bed, he is got lots of vomit around his mouth and has clearly having some issues with his breathing. And so you can see that there's something physically obstructing his airway. And the first step of airway is to remove any physical obstruction. So things that you can see. If there's vomit there, ideally you can use a sucker to remove that. Or if there's something else you can use to scoop out anything that's in the mouth. The key thing to remember is you don't put things into the back of the mouth. So if you can't see something, don't try and fish it out from the throat, because what you'll end up doing is pushing it in deeper. So only pull out things from the mouth that you can directly see, and never put your finger into beyond the teeth. Because if you do that and the patient's having a seizure, for example, they can bite down and bite on your finger, and that's very dangerous. So only ever remove things with direct vision, and never use your finger beyond the patient's teeth. So you've managed with this patient now, you've cleared out the secretions and the vomit that was blocking their airway. What's the next step, something else you can do to try and help protect their airway? Now there's nothing physically that you can see blocking it. Doesn't matter if the answer is right or wrong. There are no silly questions, no silly answers. Just anything that you can think what might be a good idea to try and hold someone's airway, help them with their airway. Anything you can think of, just write in the box. Okay, in that case, I'll give you a clue. So the key thing to be able to maintain an airway is what we call airway maneuvers. And these are positions that you put the patient's heads and necks into that make sure their airway stays open. The main airway maneuver is what we call the head tilt chin lift. What you do is you place one hand on the patient's forehead and you tilt their head backwards, and you put one hand on their chin and you pull it upwards like this. And what this does is it lifts their tongue and the soft tissues at the back of their throat. It moves them upwards, and it allows the airway to open so that air can flow in normally. So that is the first step. When any patient who's got low consciousness, that you're not sure if they're breathing or not, you put their airway into this position and it will hold it open. Second thing you do whilst they're in this position is you need to assess for any signs of life. Is the patient having a cardiac arrest, or are they just very unwell? So what you do is you put your ear to their face and you look down the chest, and you're looking for any signs of chest expansion. You're listening for any sounds of breathing on your ear, and you're feeling for any breath sounds on your face whilst you're doing that at the same time. And you do that for 10 seconds. If you can't feel any signs of life, then at that stage it means the patient is effectively, you can diagnose a cardiac arrest from that, and you start with basic life support, chest compressions and those things. But that's something we'll cover in another day. But in these scenarios, if the patient is breathing, you've managed to hold their airway open, this is the first way to check that they are actually alive still. So you're now in a position where this patient, you've gone into his room, you've cleared his secretions and the vomit from his airway, you've put his airway into an open position, so it's being held now. Problem is now, there's an additional maneuver that you can do to try and help with assessing if the patient is, how unconscious they are. In addition to the head tilt chin lift, there's something called the jaw thrust. And this involves placing your hands behind the patient's jaw and pushing it forward. And this has the same effect of opening up their airway and allowing them to breathe. This particular maneuver, though, can only be done in somebody who's very unconscious because it's very painful. So if somebody's awake, they won't tolerate this and they won't let you do it. So if somebody has allowed you to do this procedure, then it means that they are very unwell and they're very unconscious. Now you've got the patient's airway open, you can't just sit there holding the patient's airway the whole time. You need to be able to go on and examine the rest of the patient, do the other management processes. So you need something that's going to free up your hands. And what we use in that situation is something called airway adjuncts. And these are tubes that can be put into patients' mouths and noses that hold the airway open so that they free up our hands and we can go on doing the rest of the management. The main one is something called an oropharyngeal airway, or a Goodell. These can be found in any crash trolley in the hospital or in any kind of emergency cupboard, or all hospitals have their own systems for where they keep emergency storage, but this is a very basic piece of equipment that will be available in any hospital. And what you do is you first measure the airway against the patient. So they come in different sizes. The airway should sit at the entrance at the patient's teeth, and the bottom of it should rest at the level of their jaw, and that means it's the right size. And you put it in upside down so that it's pointing up towards the nose, into the mouth, and as you put it in, you twist it 180 degrees so that eventually it sits and holds the airway open and frees your hands up so that you can keep going on with the rest of the management. Again, this is only in patients who are completely unconscious, because a patient who's awake, if you try to put this into their mouth, they'll start gagging and they'll spit it out and you won't be able to tolerate it. In those patients who maybe they're not fully unconscious, but their airway is obstructing, you can hear them snoring, you can hear that they're having difficulty moving air through their airway, then those patients you can put this in, and this is called a nasopharyngeal airway. And this is very similar to the oropharyngeal, but it just involves putting some lubricating jelly on the tip, pushing it directly back through the nose, and then it will sit in the airway and hold it open without eliciting the gag reflex that the oropharyngeal airway will do. So this can be used in patients who are a little bit more awake and aren't tolerating the oropharyngeal airway. The key trick with this piece of equipment is a lot of people make the mistake of pushing it in up the nose backwards like this. And all that's going to do is it's going to push into the top of their skull. That's not going to be useful, and it's not going to go in properly. Whenever you put things like nasogastric tubes or airways into patients, you push directly backwards so that it goes in a straight line through the nose in this direction rather than going up. So that's the main thing to remember when you use this piece of kit. Fine, so just to summarize airway, we've walked into this patient's bed who was unwell. We don't know what's wrong with him, but he's clearly unconscious. We've suctioned away the vomit that was potentially something that he could choke on and block his airway. We've put his his airway into the head tilt chin lift maneuver so that it's open, and we've looked and listened to see if there's any signs of life. And we found that he is breathing, but he's completely unconscious. And the fact that he's totally unconscious means that when we let go of his airway, it closes back again. So we need to put an airway adjunct in to hold it open and let us move on to the next stage of the management. So does that make sense for everyone? Are there any questions that anyone wants to ask at this point? So, any questions? Should be a poll coming onto your screen now. If you don't have any questions, just click no. If you have any questions, type them in the box. Okay, so it looks like everyone's happy. So we'll move on to the next step, which is B. Who can tell me what B stands for? Yep, breathing. So our patient now, we're happy that we've secured his airway and we can move on to the next step. Can anyone think of any things that we could do to help assist with the patient's breathing now? So we know that they're unwell, so we need to try and support them with their breathing. What can we do to help the patient? Any ideas? What aspects in breathing, what things can we do to help with their breathing? Yeah, we can check for their respiratory rate, look at how they're breathing, that's right. What can we do to help them though? So we can look at things. Is there anything we can do to actually make their breathing better? Artificial breathing is something that can be done in ITU. That's something that will happen at a later stage because it takes a lot of time to get patients to the ITU, to have a ventilator put in. But anything more simple and straightforward we can start off with, because we're thinking about if we're on the ward by ourselves and we've just arrived and we need to give the patient something that's going to help to make sure that they get all of the necessary things into their respiratory system. So the first thing that we do in any sick person is very simple: put them on high flow oxygen. Now, there are some diseases where people might say that maybe if somebody has emphysema, that oxygen can be bad in that situation. There's some evidence now saying if people have heart attacks in the acute phase, then giving oxygen can sometimes be bad, but none of that matters because that's all something that you can worry about later. The reason we do ABCDE is because that is the order in which those problems will kill patients. If you lose your airway, you've got seconds to minutes before the patient dies. If they lose their breathing, they've got a few more minutes before they die. The circulation a little bit longer. And so all of these things we manage immediately because those are the things that can cause problems straight away, and then we can worry about the rest of the things later. Any patient who you think is very, very sick, the first step in their breathing is to just put them on high flow oxygen. If they don't need it, it can be taken off later, but always don't hesitate about doing it or worry about doing it. Put the patient onto oxygen to start with. And if they are very unwell, then what you do is you put them onto 15 litres of high flow oxygen. So it might be in an oxygen cylinder or in a tap in the wall. You turn the handle so that the ball reaches the top of it, which is normally marked at 15. And you connect up one of these bags, which again is a very basic piece of kit that is available anywhere in the hospital. It's just a mask. If you've never seen one before, then it's worth asking on the wards if you can try and take a look at what they feel like and how you use them. Basically involves connecting it to the wall. You put a finger on, there's a valve here on the entrance to the mask, and that makes the bag inflate. And that means the patient's breathing almost 100% oxygen. And you just put it straight onto the patient's face. It's called a non-rebreathe mask, and that's the first step in anyone who is unwell. Start off with B, always start by putting oxygen onto the patient. Okay, so after we've put the oxygen on, what can we do to try and get an idea of how well the patient's being oxygenated? How can we get an idea of how much oxygen their body is getting? Any ideas? Are there any investigations, any tests that might be next? Yep, exactly. Checking PaO2. Also, arterial blood gas, ABG. Those are both completely correct. The first one to start with, because it's the simplest, we always start with the quickest things and the simplest things. We can start off with a pulse oximeter. So we can check the saturations of oxygen. So these, again, in any observations machine, when the nurses are doing their observations, this is what they'll be using. You can just put a small probe onto the patient's finger, and it will give you an idea of what their blood oxygen levels are. And that, again, is very useful. It'll let you pick up if you don't know what's wrong with the patient. It'll let you rule out that there's some problem with their oxygenation early on, and it'll pick up anything that's dramatically abnormal. And it's important to remember that dropping your oxygen saturation by a small amount can lead to a big drop in the amount of oxygen your body gets. So if you're saturating at about, say, 92% on your oxygen meter, you're sitting about here. And so you've actually got quite a lot of oxygen in your system. But if you only, say, drop to saturations a little bit lower, say 70%, then you can see you immediately have dropped significant amounts. You immediately have dropped significant amounts of oxygen in your bloodstream. So only a small drop in the saturation leads to a big drop in the body's oxygen content. Fine, so going back to our patient, his airway is secure, we're happy with that. We've put him on high flow oxygen. We put a pulse oximeter onto him, and it's reading now he's on high flow oxygen that he's saturating at 100%, so we're happy with that. What's the next things we can do to look at this patient's breathing? How can we try and figure out anything else that might be wrong with this patient's breathing? Anything else we can do that will give us an idea if there's anything wrong with them? What about when you look at the patient, when you examine them? Is there anything you can see in examination? Yeah, yeah. So looking at their breathing, looking for cyanosis, those are all things we can do. So let's start off with, it's just effectively basically examining their respiratory system is what we do. So with any examination, you inspect, palpate, percuss, and auscultate the chest to try and find any other problems that you might not have seen initially on when you walked into the room. So we already know that this patient has had some secretions in their airway. Maybe they've aspirated, maybe they've damaged one of their lungs in somehow. So when we examine the chest, if we heard crackles, we might be able to pick up some pulmonary edema. If we had hyperresonance on one of the lung fields, then it might be a pneumothorax. If there was bronchial breathing, we might pick up a pneumonia. If it was very dull, we might see a pleural effusion, and so on. So just examining the chest will give us a good idea of anything else, any other pathology that might be going on in the chest. Once you've found a problem, then that's where you move on to the next stage of dealing with that problem before you move on. But this A to E approach just makes sure that you don't miss anything and that you find any problem that might be there. Whilst you're examining the chest, there's one other thing that you can also examine at the same time that will, again, be an emergency that you need to pick up on straight away. So whilst you're examining the chest, there's something else that you can examine. Any ideas what that could be? If I give you a clue, it's the trachea. Why would we examine the patient's trachea? Can anyone think of any diseases where the trachea might become abnormal that's to do with the patient's breathing? Yeah, it might be shifted. Why might it be shifted? What could cause the trachea to shift? That's a possibility. So big tumours can cause tracheal deviation, but in an acute emergency situation, so a cancer will take a long time to grow and slowly build up to move the trachea over. Is there anything that would speed up or that would cause the trachea to suddenly shift over? Yep, all the recordings are, all the lectures will be recorded, so you can watch them at a later time if your speakers or if your connection isn't very good. But just going back to the trachea, so collapse, shrinking of the lobe, that is true. If you have a lung collapse, that can cause a small tracheal shift. The main thing, whenever you see it, whenever you see in an examination, in a textbook or in real life, tracheal deviation, the first thing that you should think of should be a tension pneumothorax. So if you do examine the patient's chest and they're having problems with their breathing and their trachea has been shifted over to one side, then the first thing that you think of is has this patient got a tension pneumothorax? If we diagnose that the trachea is deviated, one lung side is hyperresonant, and the patient clearly clinically has a pneumothorax, what can we do at that point to try and manage a pneumothorax? Absolutely, needle in the intercostal space. So that's called needle thoracocentesis. Where do we put the needle? So when we decompress a tension pneumothorax, where do we put the needle? Does anyone know? Close. So this is a very, again, common question that you find in examinations, and it's something that you'll have to know if in case you find yourself in this situation. It's not very common, but it is an emergency that will kill a patient within minutes unless it's managed properly, and is very, very easy to fix. So if you do think the patient has a tension pneumothorax, you get a large bore cannula, so a big needle, and you put it into the second intercostal space in the mid-clavicular line. So you measure along the clavicle, you find halfway along the clavicle, which is about here, and you feel for the ribs, and you can count the first space and then the second space. Or you can feel for what we call the angle of Louis in the sternum. There's a sort of ridge here, and that's also at the second intercostal space. So you put your needle in the mid-clavicular line, second intercostal space. That's where you put the cannula in anybody with a tension pneumothorax. Okay? Are there any questions about any of that? Yes, that's also right. So you place the needle on the upper part of the rib. So underneath each rib is what we call the neurovascular bundle. So there are lots of nerves and vessels running on the underside of all of the ribs. So to try and avoid that, you place your needle on the top of the rib so it rests over it and you put it in through that direction. Rather than going underneath the rib, you go on top of it because that means you're more likely to miss any of the underlying neurovascular bundle. But in this situation, it's normally quite a rapid emergency. So as long as you find the second intercostal space, mid-clavicular line, it's more important to decompress the pneumothorax than worry too much about the other things. The last thing we do with the patient's assessing the patient's breathing is, as was already mentioned, an arterial blood gas. So the pulse oximeter gives us a good idea of how well the saturations are doing in the patient, but an arterial blood gas gives us a much better picture of their oxygen and their CO2 levels. And it also, at the same time, rapidly gives us results for lots of different important investigations. So it will tell us the patient's potassium level, their hemoglobin, their glucose, their lactate, their sodium levels, as well as their acid-base status, and lots of pieces of information that are incredibly useful. They all come back within minutes. So rather than having to wait for a blood test to go to the lab and take a long time to come through, most arterial blood gas samples, you can put them into the machine and they come out within minutes, the answer. So the important things, as we mentioned, to look at, we'll do another session in the future on arterial blood gases, but just to have a vague idea of the sort of information an arterial blood gas can give you. It tells you about the patient's oxygen and carbon dioxide levels, their acid-base status, gives you things about their potassium, sodium, glucose and lactate, also the hemoglobin. So lots and lots of information very rapidly that will give us a better idea about why this patient is sick and what we can do to any reversible causes of why he's sick and what we can do to make him better. So an arterial blood gas is a very important part of managing a patient's breathing. Good, so that's the whole of breathing done. Just to summarize again, airway is stable, we're happy with that. We come through, put the patient onto 15 litres of high flow oxygen with a non-rebreathe mask, find out what their oxygen saturations are with a pulse oximeter, examine the chest and look at their respiratory rate, inspect, palpate, auscultate, make sure we examine the trachea to rule out any pneumothoraces, and take off an arterial blood gas. So that is the entirety of breathing. Are there any questions about breathing? Good, so it sounds like everyone's happy. So, the next step, circulation, that's C. So we've done A, B, and we're now on C. When you come to looking at C, what we're looking at is to see how well the patient is managing to get blood and therefore all the oxygen and nutrients to all the important organs throughout their body. And there are a few clues that the body gives us to tell us how well it's managing to do that and how hard it's having to work to do those. Are there any kind of things you can think of that might give us an idea about how well this patient's circulation is functioning? Yep, colour of the hands and lips, that's absolutely right, that's one of them. Pulse rate, yep. Heart rate, how pale the patient looks, yeah, these are all correct. Blood pressure, absolutely, good. So all of the things you said are all part of the circulation assessment. Yep, feeling if they have limb temperature, if they've got cold and clammy peripheries, they're cyanosed, all of those things are absolutely correct. To start off with, the easiest thing to look at is to look at the patient's heart rate and blood pressure. And there's a couple of reasons for that. One, it allows us to see the trend over time and pick up on preempting when something's going to go wrong. So we can get to the patient before something very bad happens. I'll give you an example. If you were, say, on a ward round and you saw a patient's OBS chart was doing this, so their heart rate is going up and their blood pressure is going down, this patient is about to have a cardiac arrest at some point because something clearly has been going wrong and is getting worse and worse and worse. And unless we intervene before it gets to the point where their heart stops, then we're going to be dealing with a much worse situation where the patient's in a cardiac arrest. So if you can recognize these patterns, that's a warning sign that there's something very important we need to do. It's important to remember the body compensates in a specific order of things. So the first thing that actually goes up is your respiratory rate tends to go high. That's one of the earliest signs of being unwell. Then shortly after that, your heart rate will start to climb, and that will happen before you start to notice any changes in blood pressure. By the time your blood pressure has dropped, that means something very, very serious is already happening and you're already reaching it at a very late stage. You want to be able to pick it up before the blood pressure has dropped whilst their heart rate's going up. So you measure the patient's heart rate, you measure the patient's blood pressure, and that gives you lots of information about how hard their heart is having to cope, how much compensation they're having to do, how well perfused they're getting. By this point, when this patient's got a systolic blood pressure of about 80, he's normally at 160, so his blood pressure is now half of what it used to be. He's obviously not perfusing his brain very well, he's not perfusing his kidneys very well, so he's got lots and lots of problems. So this is a very useful first step. After that, as you've all already mentioned, looking at things like cyanosis and how well the peripheries are perfused. So this is something called capillary refill time. And what that does is it gives us a measure of how well the blood is getting to the distal parts of the body. So what you do is you take the patient's hand, you hold it at about the level of their heart, and you squeeze on their fingertip for 5 seconds, and you let go. And when you squeeze, the patient's fingertip goes white. In a normal, healthy person who's being perfused well, then this whiteness should go pink again in less than 2 seconds. If it takes more than 2 seconds to go pink, that means they've got problems with their perfusion. They're not getting blood to their body properly. Sometimes when patients have cold hands, this refill time can be slow as well. The problem with that is just because they have cold hands doesn't necessarily mean that they've got any problems with their circulation. So if you are thinking that, a better way to test this is if you press your finger on the patient's chest for 5 seconds and let go. The time it takes for that fingerprint you leave on their chest to go pink again, that's a better measure of their central perfusion. So that wouldn't matter if their hands are cold then. Their capillary refill should still be less than 2 seconds at that stage. And again, looking at cyanosis, this means that the blood itself is not carrying enough oxygen. So if you have very low oxygen levels, then you can get central cyanosis, which, as you all mentioned, is best seen around the lips and sometimes on the fingers. You'll rarely see it this dramatically on the fingers, but the lips is often a very good place to look for it. Okay, and we've looked at how well the blood's getting around the body, but then the other thing we have to look at with C is just listening to the heart itself. So examining the chest when we did for breathing last time, now we're going to listen for heart sounds. Check, are there any new murmurs that are occurring? Is the heartbeat, has the heart rhythm gone into an abnormal rhythm? Are they in AF, atrial fibrillation? Is their heart rate going at 200 beats a minute, which means there's some either a supraventricular tachycardia or VT that they've gone into? Just listening to their heart and hearing, does it sound like it's in sinus rhythm? Does it sound like there are any new murmurs? Is it functioning normally? So listening to the heart itself. As well as listening to the heart and examining the patient, are there any other things, any bedside tests we can do to get an idea of how well the heart is working? Any simple things that are available easily on the ward that we can get a better idea about what the heart is doing? Absolutely. ECG. So the next thing as part of C, we've examined the heart. Now we want to get a good idea of the electricity of the heart, how that's working. We put an ECG on the patient. That's absolutely right. All of those things have given us a better idea about what's going on with the patient, but we haven't actually done anything yet. We're just building up a picture in our ABC approach of why this patient is sick. This stage is really key because it means that we can start helping the patient. So a very important thing to do once you've got a good idea of this is to make sure that there is good intravenous access in the patient, because if they're going to need any medications, any fluids, if they need to have blood taken off, all of those interventions that are going to make the patient better are only going to happen if there are cannulas in place, because you're not going to be able to, if somebody's septic, for example, you can't get intravenous antibiotics into them unless there's a cannula there. If they've lost lots of blood, you're not going to be able to get blood into them unless there's a cannula. If they're losing fluid, if they need medications to switch their heart rhythm into a different place, any kind of problem that you're going to need to do, they need to have very, very good intravenous access. And so that means one of the most important parts of the A to E approach is to make sure that you take 2 what we call large bore cannulae. So that means cannulas that are big, ones with very big needles, because that means that you can flow lots and lots of fluid and drugs through it very rapidly. And you put them into this part of the arm in the antecubital fossa. So that's just in front of the elbow joint, because this is where the biggest veins are. And it's much better than the little veins on the back of the hand, because again, you can get drugs and fluid into the patient a lot quicker. You always make sure you have 2 as well, because if somebody's sick, they might require to have fluids and antibiotics running at the same time. If one cannula fails or something goes wrong with it and you've lost it, then it's going to waste lots of time putting a second cannula in. And note that means that the period the patient's going to go without having any fluids or any antibiotics. So make sure 2 large cannulae into the arms. When you put up those, when you put the cannulas in, whilst you've now got access, very useful point to just take off a blood sample as well. So attach a syringe to the back of the cannula, draw off 20 milliliters of blood, and then that can be used later to send to the lab to get, once you've immediately stabilized the patient, in the next sort of half an hour, you'll start getting results about important things back from the lab, and it means you can start thinking about future management quickly as well. At that point, people tend to, most of the time, running a bit of fluid at that stage is a good idea. If somebody's heart rate is quite high, one of the best things to do is just try them with a small fluid challenge. What's nice about fluid is most of the time you're not really going to hurt somebody with a small bolus of, say, 250 milliliters of normal saline, for example. There are exceptions. So if somebody has pulmonary edema and is in fluid overload and they've got a very weak heart, then giving them lots of fluid can make that a bit worse. But a small amount, just 250 milliliters, is unlikely to make that any worse. And if you do put somebody a bit into overload, it's a lot easier to remove that fluid by giving them diuretics like furosemide than it is if somebody's really dehydrated and needed the fluid and you didn't give it to them. So again, if you're not sure, giving somebody a small 250 milliliter fluid challenge just whilst you're waiting for more people to arrive is normally not going to cause too much harm. There's lots of different types of fluid that you can give. Again, we can do a session on that later, but for the time being, most people would just tend to start with saline or Hartmann solution in the initial phase of somebody who's very unwell. And you'll find fluids tend to solve a lot of problems in lots of patients. Somebody's septic, fluids are very, very good. If they are dehydrated, if they have been vomiting lots, if they've had lots of diarrhea, a lot of the time people just become unwell because they haven't been able to replace their fluids themselves, and just giving them a bit more can really make a rapid difference in the patient. All right, so we've looked at how the heart was functioning by examining it, putting the ECG on. We've looked at how well it's been perfusing the peripheries. What other organs do we need to assess how well the blood is getting to? And how else can we monitor the fluid balance of a patient? Are there any other things we can do to try and get a better idea about how the patient's fluid balance is? How about with their kidneys? Is there anything we can do to monitor how well their kidneys are doing? How well the blood is reaching their kidneys? Yes, looking at the urine volume. So what we do in anyone who's sick is you put a catheter in. So even if they don't have a urinary problem or a renal problem, the fact they're very, very unwell means you need to be able to measure their urine output and match it to the fluid input you're giving them exactly. And the only way you can do that exactly is by putting a catheter in. So anyone who's really, really sick, who's become unconscious, they've been brought in by an ambulance or they're becoming unwell on the ward, they need to have a catheter put in, and that will allow you to check their urine output. A normal healthy person should produce between about half a milliliter to a milliliter per kilogram per hour. So what that roughly equates to is a normal urine output is around 35 milliliters an hour. If somebody's passing less than 35 milliliters an hour, then there's a problem. Either they're dehydrated and not getting enough fluids, or there's a problem with how their kidneys are functioning, or there's an obstruction. But 35 milliliters an hour is the sort of number that you should be less than that worried about. And that's the entirety of circulation. So recapping everything again, we came into this room that the nurse called us in to see a patient who had become unconscious. He had lots of vomit. We suctioned out that vomit and made sure his airway was stable. We examined his breathing, checked he was on high flow oxygen, took off an arterial blood gas sample. Now we checked his circulation, keeping an eye on his blood pressure, his pulse. We put 2 big cannulae into his arms and are giving him fluids. We put a catheter in to monitor that, and we've got an ECG to get an idea of how his heart is working. So we've done a really good ABC approach, and this will apply to any sick person and is a really great place to start from. All future advanced managements that go on from that build from this basic starting point. And it means you'll have done all of the things. If, say, a senior doctor comes along later, if you've managed to keep the patient stable and do all the things the senior doctor will need ready for him by the time he's arrived. So this is something that your colleagues will really appreciate and will keep patients safe. The last step in circulation is if there are specific problems you've come across whilst you're assessing circulation. For example, if you put the ECG on and you see the patient's having a heart attack, then that's where you manage the specific problems. So if they're having a heart attack, there's something called MONA, which is morphine, oxygen, nitrates, and aspirin, which is the sort of, again, when we do our proper how to manage myocardial infarction session later, we can look into that in detail. But just specific problems that you come across in circulation, you deal with them before you move on to the next step. And those are all things that we'll address later. All right. After C, these come the last 2 steps, and these are actually a bit more straightforward. So the step after C is D, and we call that disability. What that basically encompasses is anything that affects the patient's, or sort of consciousness level. Absolutely. So how alert and awake they are. So what common things can you think of that would cause a patient to become a bit more drowsy, or to affect how well that their brain is functioning? Hypoxia is one, absolutely, and that's why we've already managed that when we got to the B section. We put high flow oxygen, so that was already dealt with. Shock is another one, and that's why we managed that when we got to the C section. We gave patients the fluids. If they were in shock, that's why we correct it. Trauma, epilepsy, good. Those are all the sort of things that can cause a patient to lose their consciousness level. Drugs, that's all correct. What we need to have then in our A to E approach is a way that we can pick up all of these things that you said. So epilepsy, trauma, drugs, all of those problems, something that means we won't miss that. So the first thing we do is we assess the patient's consciousness level. And there's an easy, quick score that we call the AVPU score that lets us do that. So if a patient is alert and awake, we call that A. If they respond to sounds, so they might be eyes closed and not talking, but if you call their name, they'll moan, they'll respond to you. That means they respond to voice. If, say, you call them, they don't answer, and you speak to them, they don't move or do anything, then if you apply a painful stimulus, say pressure above their eye or pressure on their chest, and they respond to that pressure and that pain, but they don't respond to your voice, we call that P, so that's responding to pain. And if they don't respond to anything, no pressure, no anything, that means that they're completely unresponsive, and that's a U. And so this gives us an immediate rapid scale to have an idea about how low the patient's consciousness level is and how sick they are. It roughly equates to the Glasgow coma scale that you've probably heard of before. So the patient's at a level of P, and that's around roughly a Glasgow coma scale of 8. So it means they're going to start losing their airway soon. So you know if somebody is only responding to pain, that their airway is at risk because they're not awake enough to hold their own airway open. You mentioned epilepsy and trauma and drugs. What clues can we see in the patient that will tell us about if they've had, say, trauma or head trauma, or they've taken an overdose of a drug? What things can we look at on the patient that will give us an idea about what's happened to them? Yes, we can check their pupils. So part of the disability scale is we go and examine the patient's pupils, and we're checking to make sure the pupils are equal and reactive to light. If a patient has had a head injury, or they've had a ruptured aneurysm or something that has caused the pressure in their head to go up, then they can get what we call a blown pupil. So a palsy of the pupil dilatation, and that's something that we need to be able to pick up on, and won't necessarily be something you'll see unless you work your way through the ABCDE approach, so you don't want to miss that. Alternatively, they can have problems with where their gaze is directed. So if they've got a palsy where one eye is now pointing in the wrong direction, that's again something that you might not miss unless you're looking for it. So you always check, as part of the A to E approach, has anything happened within their brain, any trauma, any hemorrhage, or have they taken a drug, for example? If somebody's on morphine, they might have two pinpoint pupils. That happens a lot if patients are on painkillers after surgery and they take a little bit too much of their painkillers and they become unresponsive. They might have pinpoint pupils. Other drugs like tricyclic antidepressants, if somebody's come into the emergency department and they've taken an overdose in a suicide attempt, for example, then they might have dilated pupils. So these are all things that are important to check to make sure we don't miss, and we do them with every sick person so that we never miss these things, okay? And as Naya has said, the last thing in disability is blood glucose. Now, I can't emphasize how important checking every sick patient's blood glucose is. I've been working for the last few years, the number of times that I've had a sick patient, not really been sure why they're sick or what's happened to them, and I've checked their blood glucose and it's come back at, say, 1.5 or really low, and then immediately you have an answer to why this patient is sick, and it's something that not only do you have an answer to, you can correct incredibly easily. Just giving them a bit of glucose, either intravenously or a glucagon IM injection, or if they're awake enough to tolerate it, some Lucozade and a jelly baby or something like that, that will immediately wake the patient up, completely make them better again. And if you don't do that, the patient can die very rapidly. So it's a really silly reason for a person to die because it's so easy to correct. So always, always, always check a patient who's sick, check their blood sugars. If somebody's unwell for any reason. It's particularly true for people who are unconscious. The most common reason that I've seen for patients in hospital to become unconscious when I've been called and there's an unconscious person, check their blood sugars, low levels, and you can correct it and they wake up immediately. It's a very nice thing to be able to do. So always check blood sugars. So that's D. So checking the glucose, assessing how low their consciousness level is on the AVPU scale, and looking at their pupils. And the very last thing, and then we finish the A to E approach, is exposure. And all that this means is a proper, full, thorough examination of the patient. So all the things that we haven't done yet. So you make sure you look at their tummy. Is it soft, non-tender? Have they got a surgical abdomen? You look at their calves. Have they got a DVT that might be causing a pulmonary embolism? You do a full general examination. And you also, especially in an accident and emergency situation, if somebody's been brought in from the outside, often if, say, somebody's had a trauma, they've had a gunshot wound or something like that, everyone will be focusing on the obvious thing that's happening in their chest or on their head or their broken leg or anything like that, but you'll miss looking at, say, the knife wound that's in their back, and no one will pick up on the fact that they've got a knife in their back or something like that. So you look at you fully expose the patient, you roll them over, you look at their back, you make sure that there's nothing anywhere that you haven't seen and nothing left that you might miss. And at the same time, whilst doing that, you make sure you check the patient's temperature, because obviously whilst you're exposing them, they can get cold during that period. But also, as part of your assessment, if you've forgotten to go back and look at signs of sepsis or signs of an infection, then checking the temperature is important. And the last thing after we've done all of that, and the patient's a bit more stable, we're happy we've managed their A to E, you get the notes, and you can look, if you haven't had a chance yet, you don't know the patient at all, look through what their past medical background is, why they're in hospital, how they got to the ward, what's going on with them, and that, with the information you've gathered from A to E, you'll be able to put all that together and have a much better idea about why this patient is sick and what else can be done. But you've kept them stable up to this point. Absolutely. And at that point, all of the later things like the laboratory investigations, the radiological investigations, that's all the specific managements of different diseases that we come to it later, but they all start with A to E. Doesn't matter what it is, they always start with A to E before we move on to that. So we've just finished, that's pretty much the whole A to E approach. I have put together a scenario where we can practice using it. So if you want, we can go through that. So if people want to go through that with me, it'll take about 5-10 minutes to do, and then we can finish off at that point. Okay, so it looks like most people want to do that. So we'll go through a case then. So let's imagine you're a newly qualified doctor and a nurse has come to you saying, again, a patient, they're having severe chest pain this time. And you come along, and the first thing that you think of, as you're now the confident doctor who knows how to manage any emergency situation, A to E. So let's imagine this. We're writing in the notes now, and you've been asked by the nurse to come see the patient with chest pain. So asked to see patient because of chest pain. You look through his notes and you see, well, actually, you already know the patient from the past. He's a gentleman on your ward, and you know why he's here. You know he came in to have bowel surgery because he's had bowel cancer. And so he came and had an operation 2 days ago to have his bowel cancer removed. You know him quite well. And you know his other past medical background. He's got a bit of diabetes. He's got high blood pressure. He's got high cholesterol. So you know who this gentleman is, and you know that he's now got chest pain. And you go to see him. What's the first thing that we're going to do when we go to see him? Yep, so it's good to have ideas in your mind about things you might think that are going on. But we've come into his room and we walk in. The very first thing that we do, the gentleman's got chest pain. What's the first thing that we assess? Yes. So we look at his airway. So we speak to him. We walk into the room and we say, "Hi, Mr. Whatever. How are you feeling?" And he says, "Doctor, I've got lots and lots of chest pain." So the fact that he has spoken to me means immediately I know that his airway is open. If his airway was closed, there's no way he could possibly be talking to me. So I have already assessed his airway just by walking in and saying hello. He's responded. I know his airway is open. After that, what do? So you mentioned we go to breathing. So breathing rate is one of them. What else can we assess? So we'll look at his breathing rate. Anything else? So the blood pressure comes in C. we'll wait that. We'll leave that to the C section. We're still on the B section now. So we measured the breathing rate. What other breathing things can we do? Put a pulse oximeter onto him. Absolutely. What else? Yep. So we're looking at his oxygen levels. So that's the oximeter. What was the most important step in B? So scanning the chest comes later. All those things come later. That's stuff that we worry. Tracheal shift is one of the things we check in the initial phases. But what's the first most important step for us making sure that B is kept stable? If somebody looks a bit unwell, oxygen. Absolutely, we put them on high flow oxygen. There is some evidence saying in people with heart attacks that high flow oxygen can make that worse, but we don't know what was wrong with him yet. So all we know is a gentleman is unwell, has got chest pain. So we measure his respiratory rate. He's breathing really fast at 25 breaths a minute. We put a pulse oximeter on, and his saturations were 85%, and that's immediately we put the high flow 15 liters of oxygen on, and that fixes his saturations. His saturation is now improved. That bit has been managed. We look at his trachea, and the trachea is central, and we examine his chest, and we can hear a bit of crackles on both bases, but otherwise his chest is quite clear. And whilst we're at B, the other thing that we didn't mention is we take off an arterial blood gas sample. So we send that off, we give it to one of the nurses or to one of the medical students around, and they'll take that to the machine, and we'll wait a few minutes for the result to come back whilst we're managing the rest of the patient. So we've got A and B sorted out now. Next is C. What are the things we're going to look for in the patients, making sure the patient's managed with C? Blood pressure, yep. Capillary refill time, yep. Pulse. ECG. Anything else? Absolutely, getting IV access immediately, that's really important. So when you're looking at paradoxical abdominal movement, that's part of when you're examining the chest, looking at the breathing, because if there's a blockage that's stopping their breathing properly, that's the reason we look for that. So that will come up when we examine, inspect, palpate, percuss, auscultate the chest. So chest x-rays and things, that's all stuff that happens later. We will come to that. That is all important. But that's something the patient will have to either be taken to the x-ray department for, or have to wait 15 minutes for them to bring a portable x-ray up. And that's all things that takes a long time to wait for. These are all things we're going to do in the next sort of 3-4 minutes. It's all very rapid, immediate management stuff. Yep, cyanosis, auscultate the heart, capillary refill, that's all exactly right. So we measure his heart rate. It's going a bit tachycardic at 110, but it's not too bad. His blood pressure is stable though, so that's good. So 120 over 80. His capillary refill is less than 2 seconds, so he is perfusing his body quite well, and there's no central cyanosis, so we're not too worried about those aspects. That's all very, very good information to start off with. We put in 2 large bore cannulas, so we've got good IV access now. And whilst we put in the access, we take off some bloods, because we might as well do that whilst we put the needle in. So we've got some bloods sent off. Some people might at this point, you could think about getting fluids, but we don't know enough about him yet, what's going on with him. So it's a good idea to maybe have some fluids ready to give if we think we need them, but we'll keep assessing the patient for the time being. We asked the nurse to put an ECG on, and so they're doing that whilst it takes a few minutes to do the ECG. So whilst we're continuing, the nurses, they're putting on the ECG electrodes, so that's happening at the moment. And the other thing we haven't mentioned is putting a catheter in. So if the patient is really sick, they do need to have a catheter if we're very, very worried about them. We've also examined their heart, and their heart sounds are normal. They've got a normal first heart sound, a normal second heart sound, and no added sounds. Good, so what comes after C? What are we going to do in the D section? Yep, check the patient's AVPU, absolutely. So he's alert, he's spoken to us. We've established he's got an A on AVPU for alert. What else? We look at the patient's pupils, absolutely. And his pupils are equal and reactive to light, so we're happy with that, they're normal. And blood glucose, brilliant. So we assess his blood glucose, it's normal, 8.7, so we know that he's not hypo or hypoglycemic, he's alert, and his pupils are equal and reactive to light. And then lastly, exposure. So what kind of things could you look for in this patient when we're going to examine the rest of him? Yep, so we look at all the areas, we examine everything from top to toe. Anything specific? Yep, so paleness we'll have looked at whilst we're looking at cyanosis and examining them. Looking if they're sweaty and clammy, yep, that's absolutely right. Anything else you can think of? Think about this patient as a whole. He's a guy who's just had an operation and he's been sitting in bed and now he's suddenly got chest pain. His saturations are a bit low. Yep, DVT, that's good. So we can look at things like examine his calves. Are his calves soft and non-tender? Because if he's got a big, exactly his legs, if he's got a big thrombus in his legs, maybe he's had a pulmonary embolism. He's still a bit early on after surgery, so normally you get pulmonary embolisms about 10 days post-operation. That's the kind of classic time, but it's something we definitely need to keep in mind. What else can we examine on this patient? He's had a big operation on his abdomen. He's had a bowel cancer removed. What other things do we need to examine with him? Exactly, we look at the wound and we look at the whole surgical site. So we examine his tummy, look at his abdomen. We look at the abdomen soft, non-tender. Maybe he's peritonitic. Maybe he's had a perforation into his abdomen. So we look at the abdomen. Maybe, like you said, with the wound, is it infected? Is there anything going on with that? Is his bowel sounds present? Maybe he's become obstructed with constipation. And whilst we're at E, and so as I said before, we look at his calves to check if he's got a DVT, and we assess his temperature to make sure he's not febrile, had any infections or anything like that. Good. So we've done a really good A to E approach with that person. And what we find as we keep going, so he's now fully assessed. We're happy. He's stable. His airway is patent. We've corrected his low saturations. His blood pressure is all stable. We've got access into him. We've taken off some blood tests. We're waiting for an ECG. His D and E we're all really happy with. So we speak to him a bit more and he tells us, well, actually, I've got this central crushing chest pain. It's moving up into my jaw and down my left arm. I'm feeling a bit short of breath with it. Feels a bit sick, a bit sweaty. And it all started 15 minutes ago. He got up to walk to the toilet. And it all started at that point when he started moving. By this point, the nurse has managed to bring the ECG to us because it's all been printed out now. So whilst we were doing that, she was working on the ECG. And this is the ECG that we've been handed. Can anyone see, those who were in our ECG tutorial we did a few weeks ago, we went through these kind of problems. And for anyone who hasn't, we can run another ECG tutorial in the future. But can anyone see what's going on in this ECG? What are the for those who are here for the system, what are the key problems that you've seen? You can see straight away on this ECG, there's something not right going on here. Yes, that's right. Leads 2, 3 and AVF. What's wrong with leads 2, 3 and AVF? So for those of you who aren't aware, these leads, something very, very bad happening in these leads. What is it? Exactly. There is ST elevation in leads 2, 3 and AVF. So if you look here, so if you look at, say, a normal ST segment, these are a bit depressed, but if you say here, the ST segment is quite flat. Here we've got these really scary ST elevation. This is all up. It's all up. And that's in leads 2, 3 and AVF. What does that tell us about? So exactly, so this is an ST elevation myocardial infarct. For anyone who was at the last session, whereabouts has this heart attack happened? Yes, an inferior heart attack. Leads 2, 3 and AVF are the inferior leads. So this patient has had an inferior myocardial infarct. So now we've done our A to E approach, and by doing our A to E approach, not only have we kept the patient stable, we've also found the diagnosis. He's had an acute inferior ST elevation myocardial infarct. We also know that we've ruled out other problems, so we are less worried now about him having a PE, because we examined for that. We're less worried about sepsis, all the other causes that might have caused him to have chest pain, we're not as worried about. We know now this is the diagnosis. When we do specific management plans, like I mentioned earlier, the management for an acute STEMI is what we call MONA before they have their cardiac catheterization and angioplasty. So they get morphine, oxygen, nitrates, dual antiplatelets, so aspirin and clopidogrel. And always, whenever you have any really severe sick patient, you always have to make sure when you're at a junior level to get a senior review. This person is very unwell, diagnosed with a heart attack, we now need to have senior cardiology or senior registrar to come and review the patient to make sure that they are managed appropriately from that point on. Number 5 is senior review. So getting either a cardiologist or a senior doctor to come and see this patient, because obviously he's unwell and he needs somebody. If you've just qualified and you're junior, you need to have somebody more senior to come and help you with this patient. Excellent. So that is it. That is the end of the tutorial. That's the A to E approach. This summary is everything that we just went through, all listed out. So it's worth having if you print this out, it's worth having it just to put up on your wall or just to have in the background. It's something that you need to absolutely memorize and is super, super important. It's second nature to me now. I remember when I was learning it, some people used to have things like mnemonics where they would have little words that would stand for things or little patterns or whatever works for you, anything that allows you to memorize this and make sure that it's really second nature and you can apply it to any emergency situation so you never find yourself in a panic. So this you can download. It's on the Serious Scholar website, and Keenan's just posted a link on the right-hand side of the page. If you click on that link, it will take you to the page, and you can have this this summary to print off and keep for future reference. And that's it. Are there any questions? Anything else that I can help with, or any things about that didn't make any sense? Good. Well, I hope you all found that useful. We're going to do, I think, we're going to do these tutorials quite regularly, and the next sessions are going to be on a kind of emergency series. So we'll go through how to manage an asthma attack, how to manage anaphylaxis, how to manage heart attacks, how to manage an epileptic seizure. All of the specific scenarios, they all start with this really important A to E approach, and then we move on from that point. So the next tutorials will all be looking at specific scenarios. If you want to sign up for those, we're going to try and do them quite regularly, so keep an eye out for them. And in the meantime, if you want to fill out a feedback form, it'd be very helpful for us to get an idea of how we can make these tutorials better for you in the future. So please fill out a feedback form. The link is posted on the right-hand side. And then other than that, I hope you all enjoy the rest of your day, and we'll see you at the next session. Thank you very much.